lung and brain, but I won't be really touching on them because I don't treat them. So I'm sort of keeping to what I know. So I thought I'd start off really because you sort of talk to patients, and I don't know what everyone's field is, but you say to them, well, do you know what radiotherapy is? And 9 times out of 10, they have no idea. And a lot of them think that they're radioactive, which they're not, because basically it's high energy ionizing radiation generated using a linear accelerator, so high energy X-rays. So basically, the machine starts off with a source of electrons which pass through a linear accelerator waveguide, where they're accelerated using microwaves to near the speed of light. And then once they're passed enough, the beam of electrons actually hits a metal target. So it's usually tungsten. And this interaction produces the Bremsstrahlung effect, which is German for breaking radiation. And that basically creates the high energy X-rays that we use for treatment, also called photons. This is a linear accelerator. This is a quite standard one that we use at the Churchill. And the X-ray beam is then shaped using collimators within the machine and or multi-leaf collimators, which basically leaves a control that are moving in and out, which direct the radiation to match the tumor's shape and therefore protect the healthy tissue. Because one of the key things, obviously, is to treat the tumor, but obviously not treat healthy tissue that is sitting nearby. Some Linacs also move around the patient. So the ones that we have nowadays are using what we call VMAT, which is volumetric modulated arc therapy, which basically just means that the beams are delivered in a 360-degree arc around the patient. And you might have 1, 2, 3, sometimes more arcs that are going around the patient, so that you are delivering a very precise dose. And this is true not just of stereotactic radiotherapy, but of any sort of standard IMRT, intensity modulated radiotherapy, which is what we use standardly to treat cancers nowadays. So how does radiotherapy work? It basically works in 2 ways. It can cause direct damage to DNA cells directly and also indirectly. So you have a direct damage to the DNA, and then indirectly by forming free radicals from water within the cell, which then go on to cause DNA damage. So if we look at sort of the key principles of radiotherapy, what we know is that cancer cells are worse at repairing damage than normal tissue. So if the DNA is damaged in a cancer cell too severely, a few things can happen. One is the cell dies outright. Apoptosis, it may stop dividing, which may then create senescence, and it could then accumulate errors and become non-functional. So cancer cells are more vulnerable to basically damage because they divide more rapidly and their DNA repair systems are faulty. So what we're really saying is that the higher the dose, the greater the chance of tumor control. However, on the flip side, the higher the dose, the greater the chance of normal tissue damage as well. And what we're looking for is what we call a therapeutic window. So you can push up the dose as high as you want, but basically at some point in time, you're going to hit that point where tumor control and complications meet. And obviously what you don't want is severe complications for radiotherapy. You might, yes, treat the cancer, but if you're leaving a big hole in the bowel, then that's no good for anyone. So what we're really looking for is that window in between, and that therapeutic window where we've got good tumor control, but we've got no or limited complications from treatment. What we do know is that we can reduce normal tissue toxicity by fractionation, i.e. breaking up the dose of radiotherapy into smaller treatments. So this was studies that they did a long time ago. So irradiated goats' testicles to sterilize them. One big dose caused infertility, but you've got a very red scrotum. Whereas you gave multiple small doses, infertility remained, but much less skin damage. And that basically is the principle of fractionation. If we go on to some radiobiology, basically what we use is model called the linear quadratic model. And basically it's basically telling us, why is fractionation important? And basically this equation tells us how radiation dose affects cell survival. So on the one side, we've got the dose of radiotherapy, which is D in this equation, alpha, which represents the damage from a single radiation hit, which is the linear curve of the equation, and B, which is damage from two small hits combined, which is the quadratic. The alpha beta ratio is the dose at which the types of damage, these two types of damage, are equal. So the alpha beta ratio is really key to the linear quadratic model. And what we know is that tumors often have high alpha beta ratios, although equally a lot of normal tissue has that high alpha beta ratio as well. Whereas a lot of normal tissue, such as the spinal cord or less sensitive tumors, have a low alpha beta ratio. If we talk specifically about SABR, and I'll go on to what difference between SABR and fractionation is, but at a high dose per fraction, the beta del D2 becomes very large, meaning there's much more lethal damage from a single treatment. And this may actually be beneficial, especially in tumors that have low alpha beta ratios. Also important when we're calculating dose is what we call the biological effective dose. And it's important because it tells us the total dose, but also how it's given, i.e. dose per fraction. It also helps us compare different fractionation schedules. So if we're looking, example, at a SABR dose where we're giving a very high dose per fraction, and we compare it to a similar dose, say, for example, we might be giving 54 gray in 3 fractions, which is 18 gray per fraction, then the overall biological dose for that is very high, around 151 gray. Whereas if you're giving 60 gray in 30 fractions, which appears a higher overall dose, biologically it's not. It's actually significantly lower because you're giving much higher doses per fraction by delivering it in the way of 3 fractions over a much shorter period of time. So if we're looking at comparison between standard fractionation and SABR, in conventional radiotherapy, you're often given 1.8 to 2 gray per fraction, and you may be giving this over many weeks, 20 to 40 sessions, 4 to 8 weeks in total. Whereas SABR, you're giving much higher doses per fraction over a much shorter period of time. So the overall biological equivalent dose is significantly higher by giving it in this way. If we talk about the sort of 5 R's of radiobiology, or the radiobiological principles that we look at, and we look at them specifically with regards to SABR, with regards to repair of sublethal damage, conventional radiotherapy allows normal cells to repair between fractions, whereas SABR, because you're giving much higher doses per fraction, basically overwhelms those repair mechanisms in cancer cells. Regards to reoxygenation, tumors often become more oxygenated between fractions, making cells more radiosensitive. However, that's less relevant in SABR because you're giving it over a much shorter period of time and fewer sessions. With regards to redistribution, with conventional radiotherapy, you may catch tumor cells at different points in their phase cycle, whereas SABR relies much more on immediate damage, so redistribution of the cell cycle is less important. Also, repopulation, tumors can start to grow back during long treatments over those long periods with conventional fractionation, whereas SABR is much shorter. We're delivering it over a much shorter period of time. It limits this. And with regards to radiosensitivity, SABR often overcomes the inherent radiosensitivity of tumors by basically the sheer dose intensity of treatment. So really the principles of SABR are treating small volumes with a very high dose, which basically we need accurate planning and delivery, and we need to minimize the dose and toxicity surrounding structures. So as part of SABR planning, what we're really looking at is we're looking at being very accurate with our contouring. So when we are delivering radiotherapy, we are contouring, we are drawing around not only where the tumor is, and I've got some pictures to show you in a second, but also any other organs that are in close proximity. We need very tight margins because we're delivering a very high dose to a very small area. We need very accurate immobilization. We need very good motion management. And what I mean by that is that things move in the body, especially if we're treating things in the upper abdomen, say, for example, the liver, that moves with inspiration and expiration. So we don't want to miss where we're treating, and we also don't want to overdose the normal tissue. And often in cases where things move in the abdomen, we create what we call the ITV, which is the internal target volume. So we take into account any movement that we may still have when we're treating the patient and when we're planning the patient. We have ways of trying to limit that movement. There may be getting patients to hold their breath during the treatment. We may have what we call gating, which is basically where we deliver it in exhale, but in that process, we need to be able to track that. So patients often have markers on them so that we know that they're holding their breath in exhale. We may compress their abdomen. So that's what we do standardly. We have a belt that goes around patient's abdomen that limits the movement of any internal organs and limits the movement of the tumor itself. Or the other option, which we don't use, but other centers do, is putting in fiducials, so markers within the tumor itself that can be tracked during the actual treatment delivery. One of the other things that we need to obviously maintain when we're planning or when our colleagues in physics plan the radiotherapy is to maintain strict constraints. So we want to get a nice high dose to the tumor. We want to get a low dose, we want a sharp dose fall off. And this involves very precise quality assessment with regards to pre-treatment verification and motion checks. So this is a tumor. This is actually a renal cell metastases in the pancreas. And what we've got here, whether the pointer works, yes. So what we've got here is the tumor itself. That's in the bright red there. So that's what we contour. So they will have had a planning scan and then we contour that. That will be our gross tumor volume, what we call our GTV. And that pink one outside is what is the ITV. That's the movement that actually has happened. We basically do extra scans. So we do inhale, exhale scans. The patient will have been compressed to limit movement, but we're basically taking into account any movement that there is. The blue around it is our planning target volume. So that is the volume that we add, which is basically taking into account any discrepancy with regards to movement that actually may happen between fractions during the actual treatment itself. And the planning target volume, we try and keep as tight as we can. And as you can see, we've got, no, it's not very clear on this, but we've got a very high dose. And the thing
what she's trying to do is mute everybody else, but not mute him. But we don't seem to know how to do that.
Very poor person. You just can't get their act together.
And this is just on the other side here. This is just our dose color wash. I'm basically just looking and demonstrating. As you can see, there's a very high dose to the tumor itself. And even within a few centimeters, the dose has fallen off considerably. So what can we treat with SABR? We've sort of touched on brain lesions, and like I said at the beginning, I won't talk specifically about that. Also, early stage lung cancers, SABR's been utilized in that setting for many years, and I'll go on to that. Again, that's not my area of expertise, but GI side of things, liver tumors, primary and secondary tumors. So primary hepatocellular carcinomas, we often treat. Secondary tumors, liver metastases from multiple sources, from the bowel, from the breast, from the lung. You know, we can treat all of those options really. We can also treat prostate cancer nowadays. So there's more research recently with regards to using SABR in low to intermediate risk prostate cancer, or even in the use of treatment with salvage, which is basically patients that have had previous radiotherapy, and you're then treating patients again with salvage SABR. I'll go on to treatment of pancreatic cancer in a little bit more detail. Kidney cancer, it's not actually commissioned yet, but it is one of those things that will be coming through the process soon. And oligometastatic disease, and what we mean by oligometastatic disease, there's lots of different ways of, I suppose, determining what is oligometastatic disease. But with regards to our commissioning, it's basically 3 sites of metastases within the body, and they can be in any part of the body. So you may have a metastases in the lung, you might have 2 in the lung, 1 in the liver, some in the lymph node, and we would be able to treat those as well. The other area that we can use SABR is retreatment or reirradiation. So say, for example, someone's had previous radiotherapy to their pelvis, they may have had rectal cancer, they may have had resection, and they may then pop up with a new lymph node within the treatment field that we've treated previously. We could then use SABR to treat that isolated recurrence. And I've got a case towards the end talking about that as well. So this is just an interesting case, and just to really just talk about the types of treatment options that we have. So this was actually a lady who had esophageal cancer. She had surgery in 2023, followed by chemotherapy. And in fact, she'd had a complete response in the primary tumor from the chemotherapy. And then it was picked up on a surveillance scan about 18 months later with a solitary liver metastases, which was unusual. We don't often see this in esophageal cancer. She therefore underwent a biopsy because we weren't sure whether this was actually a metastases from a previous esophageal cancer, or whether it possibly was a primary liver cancer. But that confirmed that it was spread from her previous esophageal cancer, and she was referred to SABR for SABR. And what you can see again is, just about make out, but that blue there is our PTV. So that's the area we're wanting to get the dose, the 100% of the dose in. And with this, we're wanting to get 50 gray. That's our prescribed dose. And you can see how precise that is around where we are saying we want to deliver that dose in this situation. Like I say, we want actually a much higher dose within the PTV, but what we want to deliver is at least 50 gray to the PTV. And you can see on this how precise it is. This around the edge is the arc, one of the arcs that you're looking at when the actual radiotherapy is being delivered using the VMAT. So that's how they're delivering. And I think this patient had basically there was 2 counterclockwise arcs and 1 clockwise arc to deliver the very tight dose that you see on this plan. If we talk about SABR within the UK and how it sort of came about. So back in 2007, the UK SABR Commission, a consortium was developed, and this was a multidisciplinary network comprising clinicians, medical physicists, radiographers, and this was aimed to standardize SABR practices and facilitate safe and effective implementation across radiotherapy centers. So initial adoption of lung cancer was back in 2009. So that was really the first use of SABR, and pretty much this is offered across the country nowadays. And then in 2015 to 2018, there were 17 centres that participated in commissioning through evaluation, and Oxford was one of them. And basically, this was looking at using SABR to treat things like oligometastatic disease, primary liver cancers, hepatocellular carcinomas, pelvic lymph node reirradiation. And basically, the information that we got from that commissioning through evaluation then allowed us to expand the SABR programme out to other centres. And actually, Oxford at the moment is helping other centres develop their own SABR programmes. So we have quite a rigorous programme with centres. They've got to demonstrate that they can basically, the clinicians can contour the organs correctly. We have a very rigorous quality assurance process through the physics team as well. But we help other centres set up their own programme with regard to this. So more recently as well, SABR has been commissioned for pancreas. And as I said before, we're waiting for commissioning for primary kidney cancer as well. We talk now and we move on to pancreas, because this is really what a lot of sort of work I've been involved in these last few years. And really, what are the challenges of delivering radiotherapy in pancreatic cancer? And there are a lot of challenges. Really, one of the key issues is anatomy. The pancreas sits right in the center of the abdomen. You have the duodenum that loops around it. You have blood vessels that are going straight the way through it. So from not just from a radiotherapy side of things, but from a surgical aspect, often patients are not operable when they unfortunately do develop pancreatic cancer. Only a very small proportion do. But that anatomy still gives us issues with regards to delivering radiotherapy. Because like I said before, what we're wanting to do is deliver a high dose to the tumour, but when you've got a bit of small bowel that's sitting right next to it, we're always worried about damaging that bowel. The other issue is movement. And as I was saying before, things in the upper abdomen move, and the pancreas moves quite considerably. Even with abdominal compression, we often find that the lesion itself can move quite a lot. Also, from a biology point of view, primary pancreatic tumours are often radioresistant. On the other side, the organs at risk, the bowel, are radiosensitive. So we're there, as we're going back, we want to get that nice therapeutic window. We obviously want to give a nice high dose to the tumour, but we don't want to give a high dose to the duodenum that's sitting right next to it. The other thing to consider is that, unfortunately, pancreatic tumours have a very high risk of micrometastatic disease. And this graph here shows early relapse following surgery. So even in those patients that you think you caught the cancer early on, unfortunately, the vast majority of them recur, and often recur very quickly within the first few months after surgery. So those are the challenges, really, of delivering SABR. And this is a tumour within the pancreas. And as you can see, we've outlined it here. And as you can see, right next to it is all the bowel. So we have to take into account that. So when we're looking at actually delivering treatment, this is treatment that's being delivered on our standard CT Linacs. So prior to each fraction, prior to each treatment, what we would do is the patient would be on the couch. We would take what we call a cone beam CT. This is a low resolution CT so that the radiologists can match where we want to deliver the radiotherapy. So they'll have the base plan that they will then try and match to. But this is the quality of image that we're seeing with regards to the cone beam CT. And you can see we've got our planning CT here, but you can tell the difference with regards to where the bowel is, where the tumour is. And this is often the problem that we have when we're treating tumours within the upper abdomen. The bowel gas often distorts, the bowel itself moves. So we have to obviously be very precise and be really sure that we're treating the right thing and we're not overdosing the bowel. So this is often the challenges of delivering SABR, a geographic miss. We might miss the tumor itself, especially if we're treating it using just our CT-based radiotherapy. And also the plan is not adaptable. And what I mean by that is one day you may find that a bit of bowel has moved closer. Well, what do? Do you send the patient away and then bring them back half an hour later and hope that the bowel has gone back into the place that you hope it was or you thought it was before? You can't do that on a day-to-day basis. You know, you can't have patients turning up for radiotherapy and you sending them off and saying, can you come back in 30 minutes? We'll hope that bit of gas has gone so that we can potentially try and treat you. You sometimes do that, but you can't do that on a day-by-day basis. And this is where the MR Linac comes into its own, really. And this is the machine here. So it's housed at Genesis Care. And it's basically a combination of a Linac with an MRI scanner. And what this is a 0.35 Tesla magnet with a 6 MV linear accelerator. From the MR, we're basically getting a combination of T1 and T2 weighted images, which we then use to basically contour. And I'll give you some examples here of the difference and the benefits of MR-guided radiotherapy. So as I was showing you before with regards to the image quality that you get on a cone beam CT, which is up here, you wouldn't be able to really see where the tumor itself is, whereas the onboard MRI images that we're getting gives us exquisite soft tissue contrast, able to visualize treatment target. The other key thing is to be able to visualize the organs at risk. What this allows us to do is that prior to each treatment, we are able to adapt the radiotherapy. So, as I was saying before, the bowel moves, the stomach often moves, especially when we're treating within the pancreas. You often find that the stomach might be a bit dilated one day, and it doesn't often fit with the fact that the patient may have eaten recently. We can just find that there's a bit of gas in there. And what this machine allows us to do is basically replan the patient before each fraction. The other thing that this allows us to do is to track the tumor in real time. So, as you can see on the little cine down below, this is basically the tumor moving up and down. And what the MR Linac allows us to do is we get the patient to hold their breath. They're able to see what we're able to see. And we get them to hold their breath for 10, 15 seconds. And the radiotherapy is only delivered when the tumor is in exactly the right place. All right, so we know that we're delivering high dose to that. We're also now able to track actually in coronal, axial, and sagittal as well. So we're able to see exactly what we're treating. This really is just the example of the benefit of the MR Linac. So this is the same patient, but you can see each fraction, the bowel is in a different place. And we're having to make those adaptations prior to each treatment. When we are replanning or when we're treating these patients each fraction, we only contour what is within the field of, I suppose, concern. So we have a ring around that is generated, what we call the NS ring, which is a 3 centimeter ring around where the primary tumor is. Because we know any dose outside of that ring is negligible. We're not going to worry about that because any dose outside that ring is less than 50% of the total dose. So we check it, we make sure there aren't any hidden hotspots in a bit of bowel that are outside of that ring, but basically we create a new plan and make sure that the dose is within that ring. So we are basically contouring the bowel within that ring, which does take a while, but actually once you get to do it and once you get a few practices, you can normally do it. And we basically have a clinical oncologist there on set for each treatment for the patient. We have radiographers and we have a physics team member as well. And we basically all have jobs that we will do during that process. So one of us, usually the clinical oncologist, will be doing the tumor, the GTV, making sure there's any tweaks, any changes that we need to make. The physics might be doing the vessels. The radiographers will be doing something else. And basically the whole process itself of recontouring the patient usually takes around 5 to 10 minutes. And these, again, are just examples of the benefit of using the MR Linac, of the guided radiotherapy, of how things move and the gating that we can use. See, for example, this one in the liver, that's the tumor in the red. And you can see how far away it is at the beginning. And that patient then is able to see what we're able to see, hold their breath. And as soon as they breathe away, the machine automatically cuts out. Obviously, this process takes longer than our standard radiotherapy machine, because when we've got a patient holding their breath in and out, yes, a good patient may be able to hold it for 25, 30 seconds. Often patients around 10, 15 seconds. So to deliver the radiotherapy often takes around 45 minutes to 50 minutes per fraction. So this is not something that we use for every patient, but this is not something that we need to use for every patient. This is a tool that we can use for specific patients where we are concerned about delivering dose in a very accurate way. So how did this come about with regards to pancreas? So actually, this came about really through COVID, and there was a collaboration between the University of Oxford, Pancreatic Cancer Research Fund, ViewRay, which basically opened up this program for patients anywhere in the country to be treated using the MR Linac through what we call the Compassionate Access Program. These were the patients that we treated during this time. 58 received treatment. The majority were male. 80% had locally advanced inoperable tumors. 80% had tumors in the head of the pancreas, which is the most common site. And 89% received 40 gray in 5 fractions, which is the dose that we basically planned to give them. So the vast majority were able to give the dose that we planned. The results from that showed that there was no significant toxicity. There was only a less than 10% grade 3 toxicity. Median overall survival was 19 months, and 1 year overall survival was 81%. And as I was saying to you before, unfortunately, these patients, especially with pancreatic cancer, even if they're able to be operated on, the vast majority are going to recur. And it's the same case with regards to delivering SABR. Fortunately, only a very small number of patients will we find patients with generally localized disease that doesn't become metastatic. And this is the problem. Following that program, we looked at, well, what difference did it make? Did it actually make a huge difference with regards to if they were treated on a standard machine and being treated on the MR guided Linac? And basically, one of my colleagues did this research. She clearly demonstrated that there was significant benefit. So without daily adaptation, without making those changes, actually almost 3/4 of patients, they wouldn't have meted our GI, our gastrointestinal tract dose constraints. So we would have overdosed the GI tract if we hadn't been able to adapt the radiotherapy. Following this, we then did a planning feasibility study looking at, could we use the MR Linac to deliver SABR? So standard SABR to the pancreas, we deliver in 5 fractions, 5 treatments. And it's usually between 40 gray and 50 gray. Commissioned dose is 40 gray, but as part of this trial, we actually pushed it up to 50 gray. But we did this feasibility first to see if we were safe to deliver SABR in 3 or even a single fraction of radiotherapy. We then proceeded on to, once we'd done that feasibility study, which showed that it was possible, we then basically sorted out a trial where we were doing it with patients, and this was Emerald pancreas. And as we see, we gave patients either 5 fractions with 50 gray total dose, 3 fractions in 39 gray, or a single fraction in 25 gray. There had only been one other center, and this was in Miami, that had delivered single fraction pancreas SABR up to this point. So we felt good about attempting this. Unfortunately, the trial was closed early. So we were recruiting really well. Unfortunately, though, the company that owned the MR Linac, or basically not owned it, GenesisCare owned it, but basically the company, the array that maintained the machine, went bust worldwide. So unfortunately, we had to close the trial early. This also meant that we fortunately stopped treating patients on the NHS as well, because we weren't allowed to. But basically, we managed to recruit 20 patients, and we looked at all the data. 100% of fractions were delivered successfully, even with a single fraction. So we managed to treat 8 patients with single fraction. Like I said, there'd only been one center in the whole world that had done that before. And we managed to maintain a high dose of the PTV whilst maintaining normal safe constraints across all dose levels. So we're actually presenting this weekend. Well, my colleague is Professor Mukherjee at ESTRO, which is our big, I suppose, radiotherapy conference in Vienna. And he's actually presenting the data from Emerald this weekend. So if you are interested, look out for that. But basically, it looks basically safe, very little in the way of toxicity, even with single fraction radiotherapy. And we've got some really good ideas about trying to take this forward as well. So I've just got a few examples really of, I suppose, SABR in different settings. So first example is a 70-year-old who was diagnosed with locally advanced inoperable pancreatic cancer. She unfortunately struggled with chemotherapy, had multiple admissions. Repeat imaging, however, showed non-metastatic. There was only a bit of mild progression in the primary tumor, but she was still inoperable. But so she was referred for SABR. At this point in time, and this was only February, as I was just saying before, unfortunately, the company went bust. And up to that point, we had an agreement through the university and GenesisCare to treat NHS patients using the MR Linac, which was fantastic. So we had access to that for around 18 to 24 months. And then, unfortunately, our trust lawyers said, because we couldn't guarantee that the machine was being safely maintained, we unfortunately couldn't treat NHS patients for around 18 months. We are now back treating patients, but at this point in time, we were still waiting for the final go-ahead. So this was February this year. So this lady had a CT scan. We were going to treat her on our standard CT machine. We'd gone back to treating patients using that machine whilst we couldn't use the MR Linac. You can see here, that's the tumor. That's the plan. It all looks good. You've got a bit of bowel around it, but not too much compromise. This is the dose that we were giving there. So there's some compromise for the bowel in front and the stomach as it comes into the duodenum. But it was a good plan, and we're all happy. You can see she's been compressed because you can see her abdomen's coming down here. So we thought, okay, that looks all good. And then you go to the cone beam. This is day 1 of treatment, and there's no way we'd be able to treat that. We can't see what we're looking at. We can't see the primary tumor. We can't see where the bowel is. We had several attempts. It was no different each day. And then, thankfully, where you can see this is beginning of March, we got the go-ahead from the trust lawyers that we can start treating patients on the MR Linac. This is the difference that you see with regards to the quality of image that you're getting using the MR Linac. This is the treatment day to day. So, compared to using a CT-based Linac treatment, I'm not saying it's impossible. You can treat patients, but it's certainly a lot harder than trying to treat someone on the MR Linac. Sorry, this is just about the workflow. I think I've sort of talked about that, about what we all do during the actual treatment. So we basically review the match, any adjustments to the tumour. We recontour the organs at risk. We review the plan. We generate a new plan. So that's the whole sort of process of going through that. Another case, this is the 84-year-old. This is a patient that we she's just going to start treatment this week, actually. She underwent, so she's a bowel cancer, so she underwent a right hemicolectomy in February 2023. This was followed by adjuvant chemotherapy. Picked up on a surveillance scan, possible enlarged lymph nodes. So she had a PET scan, which confirmed a new enlarged aortocaval node. This was in April 2024, and she was referred for SABR. So this was her SABR treatment for this node. As you can see here, you've got a bit of bowel coming across right in front of it. You've got the aorta, you've got your kidneys, and you've got your bowel. So not that difficult a plan to deliver from the perspective of treating that lymph node. Fortunately, she had then, so that was in April 24. She had another repeat scan later that year. That showed complete resolution of the previous lymph node. Couldn't see it at all. But it appeared to show a new lymph node, which was just superior to where we previously treated. So we have a SABR MDT, and there are myself, my colleague Professor Mukherjee, who do a lot of the upper GI side of things. We have another colleague, Rebecca Muirhead, who is a specialist in rectal cancer and reirradiation. In fact, she's now just national head of SABR, just taken on that role. And then we have a couple of uro-oncologists, we have a couple of lung oncologists. And often what we discuss is, and we have the guys, physics in there as well, and radiographers. But often what we discuss is more about whether it's appropriate for treatment. Technically, we can often treat patients, but it's more about whether, well, is this appropriate with regards to what we consider natural disease process. If a patient, say, for example, has had SABR to a liver metastases 3 months, and there's suddenly popped up 2 other new liver metastases within that period of time, then clearly trying to treat those 2 new liver metastases with SABR, whilst technically doable, would not be appropriate because they have got progressive disease. And often we do get referred cases, and we do often have, I wouldn't say disagreement, because we actually work all really well together, but we often, have to consider the whole process of the disease, not just whether it's technically doable. And this was actually something that we discussed with this lady, because there wasn't a huge gap between the original treatment in April 2024 and this new lymph node that popped up in January 2025. The other key consideration was there overlap with the previous treatment? When you're reirradiating, when you're retreating, what you've really got to take into account is the dose that the previous radiotherapy was given to the organs at risk, specifically in this case, the bowel. But after we discussed, we felt that it appeared to be outside of the field. It's obviously on the other side. Therefore, the dose to the duodenum was not that significant. This is actually a comparison of where the previous duodenum was and where the previous PTV was and where the new one is. So there wasn't direct overlap, but they are very close. And what we then need to do is work out the constraints that we're going to use for this retreatment. So going back to the very beginning of our linear quadratic model and our BED and our EQD2 that we all try to forget, we basically have to then work out the safe dose that we can give on this retreatment, because obviously the key thing is do no harm with regard to this. So this was sort of the calculation that we need to know. We do know that things recover from radiotherapy over time, so we also have to factor in recovery. After 6 months, with regards to radiobiology, you would say that there's been about a 50% recovery after treatment. And this was just over 6 months, so we allowed some recovery. And this was the repeat plan, basically. It met all the constraints that we needed it to. And yeah, we were happy to deliver the radiotherapy in that setting. I do have another reirradiation case, but I seem to be sort of at time now. And yeah, so maybe if I sort of open it out to any questions instead.